Anatomy of the knee. The overall structures of the knee joint include the femur, tibia, fibula, and patella. In the coming slides, we will break down the joint into specific bones, tendons, ligaments, musculature, and other various structures. Our knee is the most complicated and largest joint in our body. It is also the most vulnerable because it bears enormous weight and pressure loads while providing flexible movement. When we walk, our knees support 1.5 times our body weight, climbing stairs is about 3 to 4 times our body weight, and squatting is about 8 times our body weight. The tibia, commonly called the shin bone, runs from the knee to the ankle. The top of the tibia is made up of 2 plateaus and a knuckle-like protuberance called the tibial tubercle. Attached to the top of the tibia on each side of the tibial plateau are 2 crescent-shaped shock-absorbing cartilages called menisci or meniscus, which help stabilize the knee. The tibia is the medial, the primary weight-bearing bone. The bony anatomical locations include the tibial tuberosity, palpated in the front middle part of the knee, the tibial plateau, which is hard to palpate, but can be felt at the joint line, and the shaft, which is a triangular shape. You can run your finger down the shaft of the tibia. It may be bumpy from running into things. The fibula, the long thin bone in the lower leg on the lateral side, runs along the side of the tibia from the knee to the ankle. The fibula, or the lateral bone, carries 0 to 12% of our weight-bearing load. The bony anatomical locations include the fibular head. Once you find the tibial tuberosity, palpate to the lateral side. It may stick out on certain individuals. The femur, commonly called the thigh bone, is the largest and longest and strongest bone in the body. The round knobs at the end of the bone are called condyles. The longest and strongest bone, cylindrical shaft, bowed outward. The bony anatomical locations include the head and neck. The neck is the weakest part of the femur. The greater and lesser trochanters, the medial and lateral condyles, and the medial and lateral epicondyles. The patella, also known as the kneecap or knee pan, is a thick, circular triangular bone which articulates with the femur and covers and protects the anterior articular surface of the knee joint. The patella is found in many tetrapods, such as mice, cats, and birds, but not in whales or most reptiles and amphibians, such as snakes or frogs. In humans, the patella is the largest sesamoid bone in the body. Babies are born without a patella of soft cartilage, which begins to ossify into bone at about 3 years of age. The patella is a sesamoid bone, roughly triangular in shape, with the apex of the patella facing downwards. The apex is the most inferior or lowest part of the patella. It is pointed in shape and gives the attachment of the patellar ligament. The primary functional role of the patella is knee extension. The patella tendon enhances the mechanical efficiency of the quadriceps muscle. The patella increases the leverage that the tendon can exert on the femur by increasing the angle at which it acts. The patella protects the femoral condyles and improves the aesthetic appearance of the knee. It is attached to the tendon of the quadriceps femoris muscle, which contracts to extend or straighten the knee. The patella is stabilized by the insertion of the horizontal fibers of the vastus medialis and by the prominence of the lateral femoral condyle, which discourages lateral dislocation during flexion. The retinacular fibers of the patella also stabilize it during exercise. Knee anatomy is about the structure of the knee. That is, the parts that make up the knee. The knee is one of the most important joints of our body. It plays an essential role in movement related to carrying the body weight in horizontal and vertical directions. The knee works similarly to a rounded surface sitting atop a flat surface. The function of ligaments is to attach bones to bones and give strength and stability to the knee, as the knee has very little stability. Ligaments are strong, tough bands that are not particularly flexible. Once stretched, they tend to stay stretched, and if stretched too far, they snap. The knee is a modified hinge type synovial joint. The joint is bathed in synovial fluid, which is contained inside the synovial membrane, called the joint capsule. The knee joint connects the femur, our thigh bone, and the longest bone in the body, to the tibia, our shin bone, and second longest bone. There are two joints in the knee, the tibiofemoral joint, which joins the tibia to the femur, and the patellofemoral joint, which joins the kneecap to the femur. These two joints work together to form a modified hinge joint that allows the knee to bend and straighten, but also to relocate or rotate slightly and form side to side. The ligaments surrounding the knee joint offer stability by limiting movements and, together with several menisci and bursa, protect the articular capsule. The menisci serve to protect the ends of the bones from rubbing on each other and to effectively deepen the tibial sockets into which the femur attaches. They also play a role in shock absorption and may be cracked or torn when the knee is forcefully rotated and/or bent. The knee has a screw-home rotation that allows for full knee extension and flexion. There is an observable rotation of the knee during flexion and extension. During the last 30 degrees of knee extension, the tibia, open chain, or femur, closed chain, must externally or internally rotate, respectively, about 10 degrees. That might not seem all that significant, but this rotation is important for healthy movement of the knee. Whether it is tibial on femoral rotation, as in an open chain exercise, like in the leg extension machine, or femoral on tibial rotation, as in a closed kinetic chain exercise, like a squat, rotation must occur to achieve full extension and then flexion from full extension. This is due to factors including the shape of the mediofemoral condyle, and the lateral pull of the quadriceps is a factor in the lateral rotation during the later phases of extension. The patellofemoral joint is where your kneecap or your patella and femur, the thigh bone, meet at the front of your knee. The underside of your patella sits in a groove within the femur called the patellofemoral groove. Within this groove, the patella mostly moves lengthwise, but it has some side-to-side movement and can tilt and rotate as well. When you contract the quadricep muscle of your thigh, they pull on the quadricep tendon that attaches to your patella. This makes your knee straighten. Two other thigh muscles keep your kneecap in the femoral groove during this motion, the vastus medialis oblique and the vastus lateralis, located on the inside and the outside of your femur. The patellofemoral joint is a modified plain synovial joint. The joint capsule of this joint is continuous with the capsule of the tibiofemoral joint. The way that the patella tracks within the patellofemoral joint can mean the difference between having a painful knee and a non-painful knee. The patella is pulled by the quadricep muscle group and slides up and down during knee movements. During knee flexion, the patella slides down the femur, and during knee extension, the patella slides up on the femur. The medial collateral ligament attaches the medial side of the femur to the medial side of the tibia and limits sideways or valgus motion of your knee. The MCL has two layers. The superficial layer is a strong, broad strap, and the deep layer is a thickening of the joint capsule and blends with the medial meniscus. The medial collateral ligament and the lateral collateral ligaments have two major functions. One, for the MCL is to resist valgus force and provide medial stability, and resist external rotation of the tibia. For the LCL, it is to resist varus force, provide lateral stability, and resist external rotation of the tibia. The lateral collateral ligament attaches the lateral side of the femur to the lateral side of the fibula and limits sideways or varus motion of your knee. The LCL is a cord-like structure which runs from the lateral epicondyles to the fibular head. The anterior cruciate and posterior cruciate ligaments are the primary rotary stabilizers of the knee. They cross one another within the joint cavity in an oblique fashion. The anterior cruciate ligament attaches the tibia and the femur in the center of your knee. It's located deep inside the knee and in front of the posterior cruciate ligament. It limits rotation and forward motion of the tibia. The ACL is the most frequently injured ligament in the knee. Posterior cruciate ligament is the strongest ligament and attaches the tibia and the femur. It's also deep inside the knee behind the anterior cruciate ligament. It limits the backwards motion of the knee. The PCL is the strongest ligament in the knee. The anterior cruciate and posterior cruciate ligaments are each made up of multi-bundle structures. The ACL originates from deep within the notch of the distal femur. Its proximal fibers fan out along the medial wall of the lateral femoral condyle. There are three bundles of the ACL, the anterior medial and the posterior lateral and the intermediate, named according to where the bundles insert into the tibial plateau. The ACL provides 85% of the restraining force to anterior tibial displacement at 30 degrees and 90 degrees of knee flexion. The PCL connects the posterior intercondylar area of the tibia and the medial condyle of the femur. This configuration allows the PCL to resist forces pushing the tibia posteriorly relative to the femur. The anterior cruciate ligament and posterior cruciate ligaments have vital functions in stabilizing the anterior and posterior translation of the knee. The function of the anterior cruciate ligament is to resist anterior translation of the tibia, resist internal and external rotation of the tibia, and resist hyperextension. The functions of the posterior cruciate ligament is to resist posterior translation of the tibia and resist external rotation of the tibia. The ends of the bones that touch other bones, a joint, are covered with articular cartilage. It gets its name, articular, because when bones move against each other, they are said to articulate. Articular cartilage is a white, smooth, fibrous connective tissue that connects the ends of bones and protects the bones as the joint moves. It also allows the bones to move freely against each other. The articular cartilages of the knee cover the ends of the femur, the top of the tibia, and the back of the patella. In the middle of the knee are menisci, disc-shaped cushions that act as shock absorbers. In a healthy knee, the rubbery medial and lateral meniscus, menisci is the singular of meniscus, cartilage absorbs shock and the side forces placed on the knee. Together, the menisci sit on top of the tibia and help spread the weight-bearing force over a larger area. Because the menisci are shaped like a shallow socket to accommodate the end of the femur, they help the ligaments in making the knee stable. Because the menisci help spread out the weight-bearing across the joint, they keep the articular cartilage from wearing away at friction points. Medial meniscus is made of fibrous, crescent-shaped cartilage and attached to the tibia on the inside of the knee. The medial meniscus is larger and is C-shaped. It is thicker posteriorly than anteriorly. The lateral meniscus is also made of fibrous, crescent-shaped cartilage and is attached to the tibia, on the outside of the knee. The lateral meniscus is smaller, O-shaped, and it is equal thickness throughout. The menisci are not completely vascularized. The menisci have 3 different vascular zones. The red zone, which is vascular, 10 to 30%, the red-white or pink zone, which has minimal blood supply, and the white zone, which is avascular. Only injuries which occur in the red zone have a chance of healing. Injuries which occur in the white zone usually result in removal of the menisci, as the healing process is ineffective without blood flow. The bursa of the knee are the fluid-filled sacs and synovial pockets that surround and sometimes communicate with the joint cavity. Thin-walled and filled with synovial fluid, they represent the weak point of the joint, but also produce enlargements to the joint space. There are 5 main bursa of the knee. The suprapatellar bursa, which is located between the anterior surface of the lower part of the femur and the deep surface of the quadricep femoris, it allows for movement of the quadricep tendon over the distal end of the femur. The prepatellar bursa, which is between the patella and the skin, results in housemaid's knee when inflamed. It also allows movement of the skin over the underlying patella. The deep infrapatellar bursa, which is between the upper part of the tibia and the patellar ligament, it allows for movement of the patellar ligament over the tibia. The superficial infrapatellar bursa, located between the patellar ligament and skin, and finally the pes anserine bursa, which is located between the medial collateral ligament and the tendons of the sartorius, gracilis, and semitendinosus. Multiple other bursa exist in the knee. No muscle really encompasses the knee. Rather, many muscles affect the knee by crossing the joint. The anterior muscles include the quadricep muscle group, the rectus femoris, the vastus lateralis, the vastus medialis, and the vastus intermedialis. These form the quadricep tendon, or the patellar tendon, pass around the patella, become the patellar tendon or the patellar ligament, and it inserts on the tibial tuberosity. The anterior muscles also include the sartorius, which is the longest muscle in the body, and the gracilis. The lateral muscles include the tensor fasciae latae and the IT band, or the iliotibial band. Some texts identify this as a muscle, and others refer to this as a fibrous reinforcement of the tensor fasciae latae. This inserts on Gerdy's tubercle, which can be palpated as the bump just lateral to the tibial tuberosity, halfway between the tibial tuberosity and the head of the fibula. This provides lateral knee stability. The posterior muscles include the hamstring muscle group comprised of the biceps femoris, semitendinosus, and semimembranosus. The popliteus, which is instrumental in unlocking the knee when weight-bearing. The medial muscles include the pes anserine group. The tendons from this muscle group can be palpated just medial to the tibial tuberosity. The pes anserine is made up of the sartorius, gracilis, and semitendinosus. The degree of the Q angle is determined by measuring 2 lines superimposed on the lower extremity. One line begins at the tibial tuberosity and continues in a superior direction through the midpoint of the patella. A second line connects the anterior superior iliac spine with the midpoint of the patella. Normal Q angle for men is 13 degrees, and normal Q angle for women is 18 degrees. Women usually have a higher Q angle due to their naturally wider pelvis. Measurements can be taken either standing or laying down. A high Q angle often results in maltracking of the patella. That is, it does not travel over the front of the knee joint as it should. Over time, this can cause microtrauma to the cartilage, on the rear of the patella, which causes pain, often known as anterior knee pain, patellofemoral pain, or chondromalacia patella. Having overpronated feet also places additional strain on the Q angle due to excessive internal rotation of the tibia.